Okay. So do you see the first slide, which is allergy status identification and documentation? Okay, so this is the first slide. Okay, so again, thank you for attending this course. Inshallah, hopefully at the end of the course, you will be able to um, um, catch any events in the future whenever you are working as a pharmacist. This is a very important and critical topic, which is allergy status identification and documentation. I would like to share with you at the beginning a story. It happens a long time ago on December 2013. It's about a lady. She is 64-year-old female, and she came to the hospital on maybe around October or September. Because, or let me start from beginning. She had tonsillitis, and she went to primary clinic outside the hospital. Okay, Michael, you need full screen. Is this clear? Michael, full screen is clear? Okay.
Yes.
Yeah, so this lady had the tonsillitis. Then she went to the primary clinic outside. They prescribed for her cefuroxime, and when she took the first dose of cefuroxime, she started to have difficulty of breathing, swelling on the lips, itchiness. So what do you expect that this patient have? I need any one of you to answer. She was prescribed cefuroxime, and she started to have difficulty of breathing. She started to have itchiness, and she started to have somebody's asking prayer break, please. Let's finish the allergy. We'll take a break, and then we'll go to the last presentation. Okay. So she came to the ER, and they diagnosed her as anaphylaxis for cefuroxime. And the ER physician, he gave her the medication and therapy to treat this anaphylaxis. Do you know what's the first line of therapy for anaphylaxis? Anyone can answer the first line of therapy for anaphylaxis? Okay, until you answer the first line of therapy, I'll give you 1 minute until you type it. He treated her, he gave her the first line of therapy, they stabilize the patient, and they educate the patient that you have anaphylaxis to cefuroxime, so you need to be careful in the future and not taking this drug. And as well, they documented in our health informatics system that you are anaphylactic to this drug. Excellent. Ahmed answered epinephrine, and this is the first line of therapy whenever patient have anaphylaxis. Thank you, Ahmed. And Shahad and others anonymous. المهم. So all your answers are okay. Epinephrine. So when the patient was treated, was flagged in the system properly, was also educated. Then the patient was discharged. Later on December, the patient came with the diagnosis of bowel obstruction, and they are planned for her mesh repair. They gave her metronidazole and ciprofloxacin as empirical therapy. You know, when patients came to a hospital and do procedures, sometimes we give empirical therapy or prophylactic antibiotic. And you know, in our hospital we have ASO, which is automatic stop order. The order is stopped automatically after finish a period of time. For example, prophylactic will stay like 24 hours. Empirical therapy will stay like 48 hours. Okay. So let me charge my laptop. So the patient had this automatic stop order in the system. And when it happens, the nurse called the prescriber and asked him that this patient have automatic stop order for metronidazole and ciprofloxacin. Are you going to continue these drugs, or you will stop these drugs? What's your plan? So the physician was thinking, he was in the clinic at that day and the patient admitted in the hospital. He was thinking that I'm going to discharge this patient tomorrow, so let me give her an IV medication. So tomorrow my junior will change this IV medication easily to oral. So he prescribed for her cefuroxime 750, as you can see in the slide, IV every 8 hours. And it was prescribed through the hospital informatics system. My question to all of you, this patient, is she eligible to receive the cefuroxime or not? اللي جاوب norepinephrine is not the first line of therapy, it is epinephrine. Okay. طيب, my question for you, can we الصوت يقطع شوية، واضح الآن الصوت؟ طيب, can we give this patient, is she eligible to receive cefuroxime? What do you think? Can I give cefuroxime for this patient? Anyone? Any answer, please? Cefuroxime for this patient? Can I? No. Excellent. So we should not give cefuroxime. But unfortunately, physician ordered it and the system fired an alert. This patient have a previous anaphylactic reaction to cefuroxime. Unfortunately, physician type OK and then proceed the order. The order goes to the next stage, which is the pharmacy. And the pharmacists have this fired alerts. And it was a satellite, one of the busiest satellite pharmacy, and you will face it in the future. You will work in some busy area that you even have no time to drink water. Okay. And the pharmacist unfortunately select asterisk, enter. Now the third stage, which is the nursing. The nurse, at that time, we don't have electronic MAR. Electronic MAR is medication administration record. Okay, whatever she administers, she should record that she gave at this time and she should sign with her badge number. At that time, we have it as a paper form, and the paper form printed from the system. It was mentioned on the top of the page that patient is allergic to cefuroxime, but there was no specification what the type of allergy. So two nurses double check and they give the medication. The medication administered to the patient. Patient coded, have anaphylactic shock, coded, transferred to ICU, then the patient expired. So the patient died due to this error. Do you think we are intentionally do it to harm the patient? اوكي, كل اللي جاوبوا اجوبتكم صحيحه. اوكي. اوكي, excellent. وهيبي, no, due to history of excellent, all of you, Mariam, everyone. Okay, so thank you for your answers and this interaction through the chatting. So the patient expired. Do you think يعني الphysician, the pharmacist, the nurse اتفقوا انه to kill the patient and all of them اتفقوا انهم يعملوا override للالert عشان الpatient die? What do you think? Mariam answered no. طبعا no, we are not coming here to the hospital to kill our patient, but there are system problem. Okay, let me explain to you what is the system problem. Riyad قبل شوية, he gave you the safeguard and he explained to you the force function. Imagine the system stopped the physician from beginning for those anaphylaxis cases. Whenever patient have anaphylaxis, the system will not proceed. Do you think this error will continue and occur? No, not intentional. Excellent. But if we have force function, do you think the error will be proceed and go to the pharmacy and nursing? What do you think? Force function is very important at this stage. Okay, and we lack it in our system. Until now, we don't have it. We're working on this one. We have a task force for this one. We have a project, but still not yet implemented. Okay, so this is the first one. Second one, physician was able to override and write okay. The third one, physician was in the clinic. He wasn't in the unit, so he wasn't able to check and see if the patient is allergic or not, or he wasn't able to talk to the patient and explain to her Okay, so because he was in a very busy clinic at the 4 o'clock afternoon, you know, 4 o'clock, it means the end of the shift. So this error occurred and happened. So the other thing, pharmacist also was working in the busiest satellite. This is the environmental factor. This is the hidden factor that I told you in the presentation, the latent factor. Busy satellite covering by one pharmacist, end of the shift, error could happen. Two nurses, what's the problem? They are two nurses, check and they give the medication. Why they give the medication? You know, before, old days in the hospitals, and maybe some of you saw it, um, the answer for no, it will not stop. If we have a hard stop, it will stop me. I will not proceed for the one who answered no. But it will prevent it 100%. If you have a hard stop, it will prevent proceeding the error. Okay? Just to correct all of you, I think you misunderstand the hard stop. Okay? Imagine you have an order for ciprofloxacin, for cefuroxime, patient allergic to cefuroxime. As an anaphylaxis, the system will stop the prescriber from ordering the cefuroxime if you have a function in the system, and this will stop occurring of the event. Okay, I hope this is clear. If you need further, I can explain further. Please just write a note that I need further explanation. So pharmacy, physician, pharmacist, and the nurses in old days, they used to flag the patient or on the top of the bed to put a poster, the patient is allergic to X drug. For that patient on that bed, it was written patient allergic to NKA, patient is NKA. This was posted for the previous patient. And when the patient transferred to other, when the patient transferred, nobody updated the poster. Let me explain it again. In the old days, when the patient is admitted on the bed, on the top of the bed, they put what is the allergy type. The patient had NKA. Why? Because the previous patient who was occupying that bed was having NKA and nobody updated that poster. That's why the nurse, whenever she go inside, she see this NKA. Okay? Okay, clear. Thank you. So as you can see from the explanation, there are contributing factors. You cannot say from beginning, it's a prescribing error and proceed with blaming a physician. No, you should look at the incident from all angles, from prescribing, dispensing, administering, why it happens here and there and that. Okay, so this is what happened. It's not intentionally happen. It happens due to human factors and slips in the system. Okay. So moving to the next, we would like to share with you a statistic. This is a very old statistic. We are working on a new statistic. If you attend, inshallah, in the future, you will see another statistic with 2017, 18, 19. We have 0 events here within the hospital with allergy known cases. When you see A, B, C, D, this means that the error didn't harm the patient, or A, B, C, near misses did not reach the patient. If you see E, F, G, H, I, it means it harmed the patient and it reached the patient. It will be explained by Dr. Siraj at the end of the session, inshallah. Some definitions we'd like to share with you. What is allergy? Allergy is defined as a state of hypersensitivity induced by exposure to allergen. What is anaphylaxis? Is a severe system allergic reaction following exposure to specific substance or antigen. And what is a drug intolerance? It's defined as having threshold to normal pharmacological action of a drug. For example, there are some people like azithromycin, sometimes they give it as one tablet, one capsule once daily for 6 days. Some of them, they take it 2 capsules once daily for 3 days. Some people, when they take it as 2, they cannot tolerate the drug, okay? They will start to have GI problem, okay? So this is the drug intolerance. Going to other definitions here, cross-reactivity. This is very important for you as a pharmacist, and I would like to emphasize in this point, okay? There is in the intranet stop resource, one-stop resource in the intranet. When you go to the intranet, go to the one-stop resource, okay, and print the cross-reactivity algorithms. Read it well and understand it well. I will share it with you in the presentation. This will tell you if this substance is cross-reactive with the other substance or not. Like, you're allergic to augmentin. Is this cross-reactive if I give you cefuroxime or not? What is the percentage? Okay, very important for you as a pharmacist to understand it. Okay, the drug hypersensitivity immune-mediated response to drug agent, it could be allergic or pseudo, true allergy or pseudo allergy. Now let's go to the classification of ABRs. We have two classes, type A reaction, type B reaction. A, predictable, common, related to pharmacological action of the drug. Like, for example, if I give any one of you antihistamine, what will happen? You will have drowsiness, okay? So this is related to the pharmacological action of the drug. But type B, it's unpredictable, uncommon, not related to pharmacological action of the drug. It occurs in susceptible individuals. Like, for example, the case that we presented for you earlier, she's a normal person. When she took this drug, she have an anaphylaxis to the cefuroxime, okay? So these are the two types of ADRs. Now, if you are, and quickly please answer my question in the chat. If you are in the pharmacy and let's say you have round, okay, you are doing clinical pharmacy rotation, and one of the patients, the nurse start to infuse tazocine, and the patient start to have such reaction. What's the first thing should be done? Kindly do it quickly in the chat. What is the first thing you have to do whenever you have or start to have a reaction when you start to infuse the drug? I want an answer. Anyone? The first thing you have to do? Any answer? حتى لو غلط عادي. شعاع, can you answer? Ahmed? Remove, stop the drug, remove the drug, stop the infusion. Excellent. So all these answers are correct. Let's move to the second. Okay, so now we have stopped the drug, and all of you discontinue the drug. Correct. And now, what's the next step? We stop the medication. What's next? Done. Medication stop. Infusion stop. Check for patient allergy, then stop the infusion. No, I don't agree with you. You should stop the infusion without checking anything. Go to the nearest hospital. No, he is in the hospital. You are infusing tazocine. Discontinue immediately. Eliminate the source. Identify the cause. Before identifying the cause, what you should do? Epinephrine, excellent. So address the patient's need by giving fluids, epinephrine, corticosteroids, check the ABCs, they give you epinephrine. So address the patient's needs as a, if we put it in one sentence. Excellent, excellent reaction, thank you. Now you address the patient's need, patient is stabilized. What's the next step? You check the airway, call the physician. Excellent. What the physician should do? He should diagnose the patient, correct? Now, the patient diagnosed that he has allergic to this drug, to tazocine. What's the next step? We stop the infusion, we address the patient's need, we contact the physician. What the physician should do? Anyone? يلا guess. أنا قلتها بالسريع على السريع لما البيشنت جت على الطوارئ. Check vital signs, intubate if needed. يعني address patient's need, document the reaction. Excellent, عبد العزيز. Document the reaction. Another one said record the accident. So documentation. Excellent. He must change the medication, stop the infusion. Okay, so documentation. The physician should document it and the physician document, progress note, and he should document it in the patient's precaution screen. When you come, inshallah, in the hospital, you start your rotation. The pharmacy who do for you orientation should show you the patient precaution screen where you will find all information about allergy. Okay, and I think we are going to share it with you in the last slide presentation, or in this presentation, yeah. And then after documentation, what do you think? اللي بيكتب بالعربي يفضل ما يكتب بالعربي. دكتور سراج English speaker, for next presentation he cannot read the Arabic. Okay, so please write only in English. Okay, report the excellent, report the accidents. Where to report it? Do you know where to report it? In where? In our hospital reporting system, which is called safety reporting system. Okay, excellent. Thank you very much for your interaction. I'm proud of you, really. So what is the timing of anaphylaxis? IgE mediated reaction occurred rapidly after the first or the last administered dose. Like our case, when she administered anaphylaxis, she started to have this antibody against. Next time, or immunoglobulin, let's say, next time when she received it through the IV line, within seconds to minutes, she had the reaction. The lucky person who received it with food orally, he might start to have this reaction slowly, because until it's absorbed to the blood. I will not go through this slide, which is the therapy. I don't know, you received it, not yet, I think. The therapy and management of non-anaphylaxis. Let's talk briefly about what is the management of non-anaphylaxis. It's not that important. And this is the very important, which is acute anaphylaxis therapy, which is epinephrine, as we all of us agree. بس أبغاكم to pay attention على السترينث اللي موجودة في الأمبيول. 1 to 1,000. This is the strength that we give it through intramuscular. Okay. ما هي 1 to 10,000. Okay. So be careful when you are working in the pharmacy and the nurse rush you and call you, we want epinephrine for anaphylaxis IM. You will give her this dosage form, 1 to 1,000. Okay. The most common medications cause allergy, anticonvulsants, anti-infectious, neuromuscular, NSAIDs, and radiocontrast medium. Now, my question, and please try to type it quickly. Home, excellent SRS for the one who answers. Saudi FDA, we reported after, later on, excellent. So we reported through the SRS as ADR report, then the ADR team will send it to Saudi FDA. Thank you, Abdulaziz. So whom do you think should take the history of allergy? Ahmed, Abdulaziz. صرت عارفة أسماءكم كمان بس أشكالكم ماني عارفة. Wahabi, whom do you think should take the history? Is it you guys, pharmacy? Until you answer, I will start to tell you what are the questions for the history. Are you allergic to any drugs or food? And very important to ask about food, because you know some drugs, they have content of foods. And I'm waiting your answers. Doctor Ahmed بيجاوب. Doctor, do you agree with Ahmed ولا في أحد عنده جواب ثاني? Residents attending. So the first question, do you have any allergic to drugs or food? Because foods some drugs have content of food. What happened when you took this medication, food? When you take this medication, can you please explain to us what are the symptoms? Because sometimes the people, they misunderstand or misdifferentiate between the allergy and intolerance. Okay, when was this reaction? Was this reaction happen within this year, yesterday, or 10 years back? Okay, it makes difference. Have you taken that medication, food sense? Did anyone re-challenge you? Did anyone try to challenge you and give you the drug or not? And do you have any other allergies to close the room? So, and then Muhammad answering residents, nurses, physicians, clinical pharmacists, doctors, pharmacists, all of us, anyone dealing with medication, the answer is all of us. Anyone dealing with medication should ask about the allergy. حتى الRT اللي بيعطي inhalers, he should ask the patient not only physician responsibility, not only nurses responsibility or pharmacists, it's a teamwork, all of us responsibility. Let's move to the next case. A very interesting case. She's an 11-year-old girl. She's documented to be allergic to penicillin and cefuroxime. Okay, quickly please answer this question. She's allergic to penicillin and cefuroxime. انتوا pharmacists وانتوا اكثر ناس لازم تعرفوا الجواب هذا اكثر من الاطباء واكثر من النيرسز. Can I give ciprofloxacin for a patient who's a non-allergic to penicillin and cefuroxime? Please answer the question. Can I give? Immunologist يا العنود احنا immunologist, you mean the immunologist only the one who take the history? No, everyone. Okay, قفلنا هذا السؤال. Now السؤال الثاني, patient known to be allergic to penicillin and cefuroxime. Can I, Maryam, all of the healthcare should take the question, should take the history. Okay, so can I give cefuroxime for a patient who's allergic to penicillin? العنود بتقول لا. to penicillin and cefuroxime. خلينا نسمع أجوبة ثانية. مريم إيش رأيك؟ أقدر أعطي ciprofloxacin for patient allergic to penicillin and cipro? No, cross allergy. شعاع, yes. Somebody, yes. عبد العزيز, no. The one who answered yes is the right answer. So we can give ciprofloxacin. There is no cross reactivity between penicillin and quinolones. Okay, very clear. Please be careful. طبعا لما تكونوا في الراوند أو لما تكونوا في الفارماسي, be careful to see if there's any cross reactivity or not. هذا تقدروا تطلعوا من المايكروميدكس. Okay. So the patient prescribes ciprofloxacin, بعدين she start to have 30-minute anaphylactic reaction. They transfer the patient to PICU. They address the patient's need, giving epinephrine. They give her dexamethasone, diphenhydramine. Alhamdulillah, the patient was stabilized. No defect care in this case. But the question was, why the patient have this quick reaction? Does she have the ciprofloxacin before or not? طبعا, we consult the immunologist or allergist. She looked at the patient's file and she found out that 10 months back, the patient was received in the hospital, same hospital, ciprofloxacin, and she was reacted to ciprofloxacin. But the problem, that reaction was not documented in the patient's precaution screen. I will show it to you, inshallah, in the following slides. Patient was not educated by the junior resident who discovered this reaction. The junior resident wrote in the progress note query ADR, which is not enough. ADR report through the hospital safety reporting system was not initiated. فشفتوا documentation, how documentation is very important. عندنا 2 steps of documentation في السيستم وdocumentation في ADR team. أحيانا في physicians they forgot to document it في السيستم, فبيعملوها وين؟ في SRS ADR. وإحنا ADR team بنروح نراسل الفيزيشن نقول له tell the patient that has this allergic reaction or this side effect, do you want to flag it or not, with his justification. Okay, clear? Let's move to the next, which is allergy documentation. And now the question, whom do you think should do the documentation? يلا. مين تتوقعوا اللي لازم يعمل الدوكيومنتيشن؟ اللي جاوبوا طبعا yes we can give ciprofloxacin هي الإجابة الصحيحة. طيب لأن ciprofloxacin ما في بينه وبين البنسلين اسمه cross reactivity. Now the question, whom do you think in the hospital should do the documentation in the precaution scale or in the progress note or whatever? خلينا نركز على precaution screen هذه اللي فيها كل information allergy. مين المفروض اللي يعملها documentation؟ Physician, pharmacists, nurses. Any answer? Everyone? Pharmacists? Healthcare provider? Anyone? Physicians. عنود صح عليكي. So, the documentation in this precaution screen, it's only physician. Okay? بالdocumentation في البروجرس نوت الفيزيشن بيكتب في البروجرس نوت, النيرسز بتكتب في nursing note. Okay, pharmacists if they have a note they put it in their note. Okay, but in the allergy precaution screen, it's a physician responsibility to document that this patient is allergic to this drug, because documentation is a diagnosis procedure. diagnosis. طيب أنا ما أقدر أعمل diagnosis as a pharmacist. النيرس ما بتعمل diagnosis. The one who do the diagnosis is the physicians. Okay? Now we have 3 status allergy. Either no non-allergy, أجي أسألك عنه وإذا عندك allergy تيجي تقولي لي no. So I will enter in the system no non-allergy. Okay? Or لا سمح الله أحد جاء بالطوارئ comatose, we cannot take the history منه. This is unable to obtain and we have it in our system. But whenever the physician entered unable to obtain, the system will alert him to clinical pharmacist, by the way, ما بيقدر يعمل في precaution screen بس for your information. It's only physician. طيب unable to obtain patient comatose جاك على الطوارئ أخذنا ما نقدر ناخذ الهيستوري راح يعبيها unable to obtain بس السيستم كل ما تفتح بروفايل patient راح يطلع لك patient is unable to obtain please update it. Okay? And the last one which is non-allergy. تيجي تسألني إيش أنت allergic to what؟ أقول لك levothyroxine. تيجي تقول لي okay what happened exactly؟ أو for example أنا صار لي الألرجي في المستشفى فأنت راح تدخل الألرجين اللي صار لي منه reaction. Okay? Clear? So these are only the 3 status we have it. Non-allergy, unable to obtain or no non-allergy. شايفين هذه screen shot من البسكير؟ واضحة؟ شايفين الايكون الكبسولة هذه اللي عليها نمبر 4؟ هذه اللي احنا بنسميها البيشنتس بريكوشن سكرين اللي هم ال4 مربعات. الكبسولة هاي لو ضغطتوا عليها راح تطلع لكم هذه سكرين اللي هي الالرجي ادفيرس رياكشن انفكشن كلينيكال اليرت بريجنانسي. احنا نهتم بالنسبة لموضوع الالرجي على الالرجي والادفيرس رياكشن. احنا بس فصلناهم عشان الالرجي اتس ذا اميون رياكشن والادفيرس رياكشن اللي هي السايد افكتس. اوكي؟ if you click على مثلا على الالرجي راح تلاقي ايش الدراج نيم زي ما انت شايف الاسيتامينوفين. شايفينها؟ ايش السيمبتومز اللي صارت لما صار لك رياكشن وايش السيفيريتي. طيب فهذه هي زي ما انتم شايفين فوق شايفين patients precaution. هذه هي patients precaution screen. اوكي؟ وهذه وظيفة الفيزيشن انه يعملها ابديت بعدين. اوكي؟ ترى هذه صورة قديمة في جددنا عليها وغيرنا اشياء. اوكي؟ So another thing initiative that we have which is anaphylactic kits. Did you hear about the anaphylactic kit? This is in every single nursing unit. لسه ما ظهرت عندكم بسكرين بس بطيء شوية شكل النت. خلصت فلوسي على النت. Mike, you should pay for me. Anyhow, so this happens after an incident occurred. Patient was receiving an infusion of tazocine, and then once the nurse started the tazocine, the patient started feeling unwell. Then she called the nurse. Did anyone give me a penicillin derivative? So على طول the nurse stopped the medication and she ran out the room. What to do? What to give? What to? We don't have at that time clear policy. So a task force formulated and they discussed this issue and they decide to have this anaphylactic kit in every single nursing unit and it is now exists in the ADC cabinets. Okay. One of the items, as you can see here, is epinephrine 1 to 1 ml, 1 milligram in 1 ml, which is 1 to 1,000 injection. Okay. Another initiative. This is the one I told you. Please, when you go back, when you finish this course, when you start with the rotations with the pharmacy, let them print it for you, read it properly. If you have any question, you can call us, you can call clinical pharmacist, you can call Saudi Medication Safety Center for clarification. I'm sorry, I'm really sorry. No, not this one. Ignore. انسوا ايش اللي قلت لكم اياه. هذولا بالنسبه للانافيلاكتيك كيت. الان احنا تكلمنا عن انافيلاكتيك. داخل الانافيلاكتيك كيت راح تلاقوا هذه الالجوريثم. اوكي؟ هذه عباره عن الجوريثم تريتمنت للتشايلد والادلت. اوكي؟ 2 algorithm in 1 bag موجودة في كل الأرياس. أوكي؟ forget about what I said. This is an algorithm موجودة في الأنافيلاكتيك كيت. You need to read it. ما تستنوا إن يصير في event وتصير تقولوا كم راح أعطي دوز وإيش الدوز. أوكي؟ Be ready from beginning. طيب هذه هي الكروس رياكتيفيتي اللي كنت أقول لكم إياها. تطبعوها وأقروها. طيب واحدة انعملت للبنسلين سلفا دراج زي ما انتم شايفين. الثانية للبنسلين بيتا لاكتام. الثالثة للأوبيويد والرابعة للأسبرين وفي كمان واحدة للأنتي سيجر. إن شاء الله مع الأبديتد راح تلاقوها لكن موجودة في الوان ستوب ريسورس. أوكي This is only an information for you. If the patient known to be allergic to drug, you should not pre-medicate the patient. And the pre-medicate the patient means giving them antihistamine. تعرفوا انتوا اللي عندك اللهم صل وسلم على نبي محمد الانفوتيراسين بي نعطيهم احنا pre-medicate صح؟ بس إذا patient known to be anaphylaxis للدرج ما بتعطي pre-medication. The only exception to the rule is we are pre-medicating only for immediate hyper sensitivity reaction to radio contrast media. They discovered that most of the immediate reaction to radio contrast media are hypersensitivity, not true allergy. Okay, so some recommendations to reduce the risk of medication errors with non-allergies. You need to check the allergy. كل مرة تفتح البروفايل patient روح على الكبسولة هذه وشوفها. You need to understand the allergy والcross allergy. لا تقول خلاص بعدين بقراها قبل الإكزام. It's not exam things. It's your career. هذا ماشية معاك طول عمرك. Okay? You need to educate patient. لا تقول في ال ACC زحمة وما لي خلق وما راح أسوي له. لا. You should educate the patient. إذا كنت clinical pharmacist educate the patient. إذا كنت rotation وعليك إنك تعمل education patient you should educate the patient. لا تقول إن البيشنت ما راح يفهم. لا. ما شاء الله الناس الآن حتى العامية صاروا يعني بيفهموا في الهيلث أكثر منهم. Standardize the history with documentation, and this is we have it in our hospital. Maximize the impact of computerized prescribing, and we really maximize the impact of using the health informatics system. This is NGHA care. أبغاكم كلكم تنزلوها إذا كنتوا eligible للحرس الوطني. تنزلها عندك وهنا تقدر تطلب ادويتك، تقدر تشوف الالرجي ستاتس تبعك، تقدر تعمل تشوف الانفورميشنز احيانا تلاقيها appointments كذا. So when you upload it in your phone بعدين تيجي هنا مثلا rotation او كذا وعندك education patient, you will tell him, you will ask the patient to upload it in your phone, and this will help you in finding the appointments, finding the medication refill, finding all details about your medications. Okay, so let's go to the next slide. This is how it shows the allergy. خليها تطلع لكم بس على السكرين. شايفين كيف تظهر هنا طبعا الام ار نمبر، وانت تقدر تعمل ابديت تحدث معلوماتك، ما تحتاج انك تكلم الريجستريشن. We have policy about allergy and hypersensitivity recording and documentation. Okay, and this is the policy if you want to access it. I have a question for you, and it is in the exam. I need you to answer it quickly in the chat box. What is the reference site for the medication safety or medication safety information for the National Guard staff? Is it؟ بعطيكم خيارات وجاوبوني على السؤال. خلينا نعيد السؤال. What is the medication safety information link or site? I don't know how it's phrased in the exam for National Guard staff. Is it one-stop resource? Is it Micromedics? Is it Saudi FDA? جابوا لي إياها على الchat box. One-stop resource, Micromedics ولا Saudi FDA. So this is the end of the presentation. استنى منكم الأجوبة. تاخذوا 5 minutes break عشان نبدأ في المحاضرة اللي بعدها. يلا أبغى أشوف الأجوبة. Michael, don't hear I'm cheating. I'm giving them questions. Immediate reaction to pre-medication. What exactly? Okay, I have here a question. In case RCM, immediate reaction, radio contrast media, pre-medicate with what exactly? Usually pre-medication is known as epinephrine, diphenhydramine, الأشياء هذه. Fluids we give the patient. Micromedics Muhammad. One-stop resource, I don't know whom. Saudi FDA. One-stop resource, one-stop. Saudi FDA, Saudi FDA. One-stop resource. The one who answered one-stop resource is the right answer. Okay? The one-stop resource is our resource for medication safety information. Now, Michael, we want to take a break. 5 minutes. Please, audience, بليز 5 minutes. اللي يبغى يصلي يصلي، اللي يبغى يشرب يشرب، وانا قاعده القي المحاضره عشان نخلص بدري لانه صارت الساعه 4. طيب. So 5 minutes break and I will come exactly after 5 minutes. I will upload the next presentation, Michael, until they come back, okay?
Okay. I'll just share a timer, 5 minutes.
Okay.
Hi, Doctor. I'm good. Gotta still have one high alert medication, maybe 20 minutes. Yes. Were you able to see the slides now? Okay. I will be the one to click when you say next slide. Yes. I'll try to give you a control. Yes. No, we're on live. Yeah. Yes. Okay. All right. Okay.
Hello, Michael, can you hear me?
Yes.
Okay, good. Good. So the microphone works at least.
Okay.
Mike, can you see the slides?
Yes, full screen, please.
Okay, wait. Clear?
Yes.
attendee, are you available? بداكم تصلوا ولا قروشناكم؟ هذه محاضرة مهمة فماني حابة صراحة أبداها وما في أحد. أي أحد موجود ممكن؟ chat box please. محمد yes yes. Abdulaziz yes. Okay. Looks all of you back. إن شاء الله. I'll be at the beginning شوي slowly عشان others to catch. Excellent. So all of you here. مساء الورد again وخلينا نبدأ بالمحاضرة هذه. Very important lecture راح تواجهوها كثير في الفارماسي براكتس حقكم. I don't know if you have it in your school اللي هي ال high alert medication. We are here. Okay. Excellent. So most of you here. High alert medication, one of the important topic اللي فيها الفارماسي involvement very high, اللي فيها انتوا لازم تكونوا aware about it and very careful when you deal with this medication. من اسمها high alert medication, it's something that should click in your mind that I need to be careful. Is the dose correct? Is the infusion okay? Is the timing? Everything you have to be careful with these drugs. There is a reason why we call these drugs as a high alert medication. I'll share it with you. Okay. Now, this is my learning objective, definition, our experiences and reporting, common risks and online strategies to improve and minimize risks, then the policy procedures. You can see this definition and you have an exam at the end of the day. Pay attention to this definition, okay? ما أبغى أحد يغلط في هذا السؤال, okay? High alert medications that pose an increased risk of causing significant harm to patients when it's used in error. So these drugs will increase the risk to cause harm to the patient if I use it in error. في أحد يقدر يعطيني example على high alert medication؟ مريم تقدر تعطيني example على high alert medication؟ عبد العزيز؟ عنود؟ Anyone can give me a high alert medication example عشان نعطي عليها أشرحها بالنسبة للديفينيشن. أي أحد يعرف إيش هي الهاي alert medication؟ medication إذا عطيتها للبيشنت بدوز غلط أو بروت غلط أو whatever, it will increase the risk. It will increase the significant harm. Warfarin, excellent. Warfarin, all of you warfarin, excellent. اللي يكتب بالعربي قلنا ما نكتب بالعربي. Phenytoin is not high alert medication. Warfarin, insulin, excellent. So warfarin هو أكثر إجابة أنا شايفيتها شكله كثير ركزوا عليكم فيها في الكلية لأنه إحنا عندنا anti coagulant clinic وفيها warfarin. So warfarin إذا مثلا خلينا نقول patient should receive 1 ملغ وبالغلط أنت أعطيته 5 ملغ. Risk of bleeding, okay, very high, والdeath كمان risk is high. طيب. So warfarin, heparin, insulin, هذه الميديكيشنز هذول احنا عندنا هنا في المستشفى high alert medications. طبعا عندنا لستة الهاي alert medications. Now just to share with you outside statistics إذا واضحة بالنسبة لكم الجراف شوفوا هنا بالنسبة للreports through the ISMP Canada the highest insulin which is high allergy medication morphine hydromorphone heparin fentanyl هذول top medications that harm the patients في ال ISMP Canada reports من 2001 ل 2005 إذا رحتوا للميد ماركس 2008 كمان راح تلاقوا similar incidents insulin heparin hydromorphone fentanyl and morphine طيب let's go to our National Guard statistics زي ما قلت لكم هذه all dated we have the new statistics for 2019 and for 2018 بس ما هي بعيدة عن هذه الستاتستيك زي ما انتم شايفين الهايست بالنسبة لل 3 years هذه anti-thrombotic agents like warfarin, heparin, opiate narcotics like morphine, fentanyl, chemotherapy agents. Yes, Michael, are you talking?
I'm sorry.
Mute, please. And then the insulin. If we want to share with you the harm events with high alert medication, do we have? Yes. Do we have death incidents? Yes, we have it in 2016. So we need to really be careful with these drugs because any error could really harm the patient, could really cause harm. شايفين الharm من E, F, G, H, I with death اللي هو ال I. Okay? So my question أو حيكون صعب إلا إذا جاوبتوني بسرعة. الأوبيات إذا أعطيت أنا الأوبيات ولا هم already كاتبينكم الإجابات. الأوبيات إذا أعطيته أنا in a high dose will cause respiratory depression زي ما أنتم شايفين. طيب؟ الانسولين اذا اعطيته in high dose will cause hypoglycemia بس اذا اعطيته في low dose high dose حيسوي hypoglycemia معروف بس لو اعطيته low dose ايش البيشنت بيصير عنده hyperglycemia اوكي الانتي كواجولانت high dose will cause bleeding طب لو انا بالغلط المفروض اصرف له 5 ملغ وصرفت له 1 ملغ ايش البيشنت راح يصير عنده حيصير عنده clot formation اوكي يعني في الحالتين هاي واللو دوز لازم اكون careful لما اتعامل مع هذه الادويه اوكي so if you converted these events to money it will cost $3.5 billion annually with these adverse drug events طيب let's share with you this is a case still not appear in your screen بس حبدأ فيها a 44-year-old male obese male he was obese 100 plus kg history of pulmonary embolism. He was controlled with warfarin. He admitted to the hospital for elective surgery, and after the surgery, they gave the patient enoxaparin 120. His weight was 120 kg, by the way. Okay, so they gave the patient enoxaparin 120 milligram every 12 hours, and he had compromised renal function. Are you happy with this dose of enoxaparin, please, anyone? Clotting, hyperglycemia. ما شاء الله والله يعني أتمنى لو إني قاعدة أعطي المحاضرة أونلاين يعني on site together لأني أنا شايفة ما شاء الله ناس very active وما شاء الله عليكم. بوتاسيوم اللي كاتب بوتاسيوم اللي هو حرف M. It's concentrated potassium, not potassium diluted, okay? As a high alert medication. So are you happy with the dose of enoxaparin? يلا انتوا pharmacist وintern على وجه تخرج حيجيكم هذا الاوردر في الانباتient. Are you going to dispense this order? Massive, excellent. No. Yeah, so we should not give the dose. أول شيء البيشنت impaired renal function، ثاني شيء الويت ما بنعطيه بالويت في عندنا maximum dose للإنوكسابارين. So we have to be careful. اللي صار للبيشنت was transferred to ICU, clinical picture of shock, turned to be hemorrhagic shock complicated with multi-organ failure and death. So the patient died due to this simple mistake. So let's move to the classes of high alert medication. بتكلم لكم عنهم class. حنبدأ بالانتي كواجولانت وزي ما احنا حكينا الانتي كواجولانت example عليها الهيبرين، example عليها الورفرين، وتقدروا تشوفوا هنا بالبيكتشر اللي موجودة 2 bags بس لو تلاحظوا وتدققوا عليهم هذول 2 bags they are heparin بس with different strength. فتخيل انت في اليونت او في الفارماسي قاعد طلب منك هيبرين رحت لفيت اخذت الباج وهم عاملينهم ستورنج جنب بعض. هذه الكونسنتريشن العاليه على اليمين والكونسنتريشن الواطيه على اليسار. رحت انت اخذت الكونسنتريشن العاليه بالغلط بدل قليله الكونسنتريشن ودسبست للنيرسينج والنيرسينج اعطت انفيوجن غلط. فهذه فيري يعني دانجرس اللي هي بنسميها الكومن ريسك which is اللوكالايك او اللوكالايك ميديكيشن. يكون عندي different strength للهيبرين. why I should have a standardized concentration للهيبرين or those drugs. بعدين عندك المشكله الثانيه في الهيبرين اللي هي الكومبليكيتد دوزنج ريجيمن. اوكي according للبي تي انا راح اعمل انفيوجن كذا، وعشان اعمل انفيوجن 500 يونت لازم اشوف كم ام ال اي هاف تو انفيوز، وعشان اعمل اشوف كم ام ال اوكي خليني اشيك على ال كم كونسنتريشن محضره. ف it's very complicated وصعبه ما هي سهله. فهذه كمان one of the commonest risk for the error. She scared me. low molecular weight heparin one of the commonest risk. طبعا low molecular weight heparin محضرة بالمانيفاكتشر 30 40 60 80 ready made للادلت. I think I have one here and I can share it with you عشان أوريكم إياها. I don't know, can you see my picture? Can you see me? شايفين? I don't know if you can see. This is the enoxaparin. Michael, can you see?
I can see you, but live is not showing your video. Only the sound and the presentation.
So they cannot see the face.
Yes.
Okay, unfortunately otherwise كنت حوريكم إياها. لكن هي syringe ready made للأدلتس. عشان أنت تعطي للبيدياتريك لازم تحضرها، تتأكد من الدوزنج وتتأكد من الديليوشن وتتأكد من السرنجات حضرت صح أو غلط. يعني very critical drug خاصة لمين إحنا بنحضرها للبيدياتريك population. Okay, so these are the commonest risk. The common strategies راح تتكرر في السلايدات الجاية اللي هي standardized labeling و packaging. protected standard concentration. ركزوا على الاستراتيجيز جاية بالامتحان. Okay. anticoagulant services. لما يكون عندك service anticoagulant معروف مين اللي قاعد يتابع البيشنت اللي هم clinical pharmacists. That's perfect. counseling. لازم تشرح للبيشنت. متى تشرح للبيشنت؟ لما يجي يطلع من المستشفى؟ لا، من لما starting therapy discharge مع first anticoagulant clinic when necessary. use the smart pump. لا تستخدم البامب اللي بدون ما تستخدم الدراج library. So you need to be careful when the patient is admitted. اسأل الميديكيشن ايش اللي بياخذها وكم الدوز، وريني الميديكيشن. لا don't just hear from them من غير ما تشوف الأدوية which is the medication reconciliation. هذه الاستراتيجيز راح تعمل انها prevent medication errors. Okay. So this is the first class which is anticoagulant. Now let's move to the second class which is opiates. زي ما انتم شايفين هنا في عندنا 2 ampules. I'm looking at the chat if there is any question or anything. We see slides only. You don't hear me? We can't. Okay. So for the enoxaparin, unfortunately. Let's raise this issue, Michael, for the technical people that they cannot see us. Okay. So now let's go to the opiates. المشكلة في الأوبيات اللي هي اللاسة lookalike، وزي ما انتم شايفين two ampules they are lookalike to each other. حاجة ثانية اللي هي using leading zero. lacking of leading zero. في عندكم شغلتين لازم تركزوا عليها. في حاجة اسمها leading zero وفي حاجة اسمها trailing zero. اوكي. الزيرو اللي نستخدمها اللي هي leading zero اللي هي مين؟ اللي هي 0.8 ملغرام. حلو؟ لكن ما تستخدم 8.0 لانها تنقرا 80. اوكي. والاولى بتنقرا 8 اذا ما حطيت لها الزيرو. اوكي. فيو نيد تو بي كيرفول. اللي بنستخدمها الليدنج زيرو. حسال السؤال وجاوبوني اياه على الشات وراح اكمل البرزنتيشن. which zero we are using؟ leading zero ولا trailing zero؟ again which zero we are using؟ leading zero ولا trailing zero؟ اوكي. وحيجيكم مثلا في الامتحان مثلا aspirin 81.0 مثلا QD مثلا. ايش الاخطاء في هذا السؤال؟ اللي هي دوت زيرو هذه غلط. trailing zero ما بنستخدمها. حلو. والكيو دي اتس ابريفيشن، we should not use abbreviation. كمان من مشاكل الاوبيويد انك انت اغلب البيشنت we should load them بعدين نعملهم maintenance. احيانا بالغلط النيرس بتعطي اللود وبتعطيها infused وما بتتوقف، ف بتعطي high dose in a very short time. اوكي. كمان في عندنا خاصه في البيدياتريك different concentrations للاوبيويد و improper disposal للترانسديرمال باتش. الفنتانيل I wish if we are in front of each other، بس الفنتانيل في أحد يعرف how can we dispose it؟ أحسنت يا أمجد. leading zero leading zero leading zero excellent، كلكم صح إجاباتكم 0.8 برافو عليكم، ما حدا جاوب trailing zero برافو. so خلصنا هذا السؤال. السؤال الثاني transdermal patch، في أحد يعرف وين نرمي الفنتانيل باتش لما أخلص استخدامها؟ حاولوا تجاوبوها while I'm doing the strategy. ترى الاستراتيجي مكررة تقريبا مع الأذرز. We should use the toll monitoring. Okay. We should use the timeout if we are doing intrathecal. We are encouraging people for the PCA patients, control analgesia, educate them, give them the quick reference, using the smart pump, proper patient education خاصة على الباتشز. anyone في أحد يعرف وين نرميها؟ الباتش وين نرميها؟ hazardous waste. لا patient في البيت ما عنده hazardous waste، ما هو في المستشفى. وين نحطها يا بدر؟ واحد بالبيت اتصل عليك قال لك عندي أنا فنتانيل وين أرميها؟ إيش بتقول له؟ بالبيت ما عندي hazardous box يا ريم. hazardous disposal في البيت ما عندي. أنا بالبيت أنا ما عندي، ماني educated. خليني أختصر عليكم بالنسبة للفنتانيل باتشز. طبعا الباتشات أي باتش عندك فيها sticky area وفيها non sticky area. أول شيء تعمل إنك تعمل fold على sticky area قفلتها خلاص. ثاني شيء تروح على دورة المياه، تشرح للبيشنت تروح على دورة المياه تحطها في التويلت وتعملها flashing. حلو؟ This is the way how we should educate our patient to dispose. Excellent يا العنود. Toilets. Excellent. Time out strategy. What is the time out strategy؟ طبعا في التايم اوت هنا ما راح اركز لكم عليها، لكن راح اقول لك لما يجي بيشنت ينعمل انتراثيكال ولا عندك في السيرجري الاو ار يعملوا تايم اوت، انا ما حضرتها ولكن بيوقفوا بيرجعوا يراجعوا كل شيء، و sometimes عندهم تشيك ليست to check. If they agree everything okay they will proceed and go ahead give the medication. طيب we tell them to bring it here in the hospital. لا طبعا لأنه ممكن أحد يستخدمها من غير ما يعرفوا. we should destroy it first. coffee cup. بالنسبة للكافي كاب في some الميديكيشنز yes بنحطها على الكافي. طيب let's go now to the next slide. معلش بس خليني أرد على الجوال BMS. Okay, now this is the opiate strategies. Okay. Now the third class which is chemotherapy agents. Chemotherapy agent عندك very dangerous drug, toxic drugs. يعني تخيل تعطيها in wrong doses مثلا فهذه مصيبة. يعني عندك مثلا methotrexate. Methotrexate it's given in a cases of dermatology or rheumatology. طيب it should be given weekly بس للأسف وبالغلط الطبيب دخلها daily ومشت على الفارماسي. هذه error. Vincristine بالغلط بدل ما تنعطى intra vascular انعطت intrathecal والبيشنت راح فيها neurological problem واحيانا death. Lomustine given daily بدل weekly. Carboplatine, cisplatin sound alike medications الايرور فيها عالية. فالmost common risks للكيموثيرابي الانتربشن، اللاسع، الكيموثيرابي total courses، مثلا استخدمت outdated lab result، الروت غلط intravenous بدل intrathecal. فهذه هي الكومن ريسك. مثلا ال very distance between الفارماسي والاريا اللي بيعطوا فيها الكيموثيرابي. الاوردر ست في مشاكل حق الكيموثيرابي. مثلا عندك double check against actual والprotocol. no abbreviation، مثلا استخدم abbreviation، أو مثلا أنا آسفة جدا oh my god. So الاستراتيجي الآن أنا قاعدة أتكلم الآن عن استراتيجي. خلصنا الريسك المسكوميونيكيشن، total number of courses، excessive interruption، اللاسة، الباكجينج، الروت اوف ادمنستريشن، هذه ريسك. خلينا ننتقل على اللي بعدها اللي هي الاستراتيجيز. انه كيف انا ابريفنت الايرورز. اول شيء ما تعملها ستورنج للكيموثيرابي الا في الفارماسي. ثاني شيء لازم تستخدم اوردر سيتس وتشيك على الاوردر سيتس انها مبنيه صحيحه في الهيلث انفورماتيك سيستم. ثالث شيء لازم تعمل independent double check للكيموثيرابي. no abbreviation، ما تستخدم abbreviation. avoid excessive precision. ايش يعني؟ يعني لا تكتب للفارماسيست 919.57، خلاص اعطيه 920 او 900، يعني اعملها round up or down. okay. There are some chemo medication given for non-oncologic indication. You have to have an order set for those cases. طيب فانكريستين حلينا مشكلتها اللي هي لازم تتحضر في ميني باج، فإذا تحضرت في ميني باج there is no chance to be given intrathecally. طيب الميثوتريكسات اللي بالغلط أعطوها daily سويناها defaulted في السيستم once weekly. So أنت ممكن تلعب بالسيستم، ممكن تشتغل على السيستم، على البروتوكولز، على البوليسي، على الأوردر sets to prevent such events. Okay. Now we will move to the insulin. This في أحد بيسأل بيقول once disposing the medication through the toilet exposed environment, this recommendation came from ISMP. ما ظنيت هي أحد عاد بيروح للسويج. Insulin now common risk lookalike. حتروح على الفارماسي وتشتغلوا وتشوفوا how they are using or buying from the same company, so they are lookalike to each other using the unit. It's misread as zero, incorrect dose, lack of dosing checking. طيب احنا عندنا في المستشفى الهاي alert medication insulin only the IV. okay. So what are the common strategy؟ وهذه الcommon strategy حتجينا في الامتحان، فخلينا نركز. spell the units والnumbers. لا تقول 8U. okay. It can be read as 80 80. Use smart pump infusion. Use an order set زي الكيموثيرابي. Use infusion protocol for some cases مثلا in cardiac sciences مثلا. okay. And store it separately and labeled. آخر high alert medication we would like to share with you is the concentrated electrolyte. والمشاكل فيها غالبا بتكون lookalike. شايفين انتوا في screen how they are lookalike to each other. The common strategy to prevent it, we should store it in red bin with lid، ولما تشتغلوا في الفارماسي راح تشوفوها. وإذا كنت راح تعملها storing في patient care area, it should be in ADC with locked lidded. إذا كنت تبغى تخزنها في الكراش كارد أو black box لازم يكون عندك label high alert medication concentrated electrolyte must be diluted, and you should use the standardized medication labeling. Those are the area that we can give them the authority to have the medication. طبعا احنا عندنا هنا في المستشفى في central region we don't have concentrated electrolyte في patient care area. طيب we always give them diluted. okay. Recently we approved one for the PICU اللي هي sodium chloride 3%. so اللي يبغى انه يدخلها عنده لازم يجيب justification ويجي يعمل present للموضوع عندنا في الميديكيشن safety to be approved، واحنا نشيك عليهم ونشيك على البراكتس حقهم. حلو. بس هذه هي الاريا اللي تقدر تعمل ستور للمغنيسيوم سلفيت concentrated والبوتاسيوم كلورايد. so general strategy هي هذه اللي بتجينا بالامتحان اللي هي toll man lettering، اللاسة، high alert on the storage، high alert must be stored in red bin. بالنسبة للي concentrated electrolyte parenteral skeletal muscle relaxant should be in red bin with lead. إذا أنت عملت لها storing في patient care area طيب اللي هي زي اليونتس حقات النيرسينج يونت لازم تكون في ADC locked leaded. okay. using the CPOE warnings and alerts. Independent double check, it's automatically done in the pharmacy, but we are always encouraging the nursing to do it. Independent double check, it's done by two different staff, okay, separately without distraction. أنا pharmacist الأول انا بشيك عليها عفوا انا التكنيشن راح احضرها، اشيك عليها، اشيك على الام ار نمبر، اشيك على الدوز، اشيك على كل شيء، اشيك على التحضيره، الفوليوم، الكذا، خلصت. الفارماسيست راح يجي راح يشيك على كل شيء، الفايف رايتس او وات ايفر رايتس، رايت بيشنت، رايت ام ار نمبر، رايت دوز، رايت dilution, رايت concentration, رايت everything done. Are you happy? Yes, I'm happy. We can go ahead. not happy, are you happy? Sorry. يعني أنا بقول لك إيش اللي finding تبعي وأنت تقول لي إيش الfinding تبعي. Okay, you are happy. We can go ahead and dispense it. Also in the nursing the same. Separately, without distraction. نعملها verification then at the time of administration وبعدها they can proceed and administer medication. So ما حدا يقول إنه إحنا pharmacy ما بنعمل independent double check. No, we do it. هي ما هي necessarily to be pharmacy with pharmacy. It can be pharmacy technician with pharmacist. Okay. We have policy. If you need further information about it, there is an appendix D. It gives you a detail in each single process how to deal with high alert medications. We have another appendix for the list of high alert medications. So even in the one-stop resource, the standardized labeling, we have one link for the high alert medication standardized labeling. And sometimes for physicians and pharmacists, there is a pop-up message for drug interaction information or dosing or whatever. So we need to really pay attention for this pop-up message and don't ignore it, okay? Because sometimes it's give you an important information that if you ignore it, نفس موضوع الالرجي, when they ignore it, the patient died, okay? So at the end of this presentation, standardize the work. You will get, inshallah, good patient outcome and a safe patient outcome. Is there any question? أرجع أعيد. Dr. Siraj will present now the following presentations. If you want to write in the chat box, you need to write it in English only, no Arabic. Okay. Mike, from my side, let me see, there is no questions. Hopefully, inshallah, you will pass the exam. الإكزام مرة سهل حلو وأعطيناكم بعض الهنت عليها. Mike, you can share the presentation for Dr. Siraj. There's.
Assalamu alaikum. Hello, Mike.
Well, Dr. Siraj, I think you can control.
Okay.
All right, you can move the mouse. All right. Go ahead, doctor.
Yeah, no, I'm just. How do I advance the slide now?
Just click on the right side.
On the right side. It's not moving. Okay, there.
It is clear for us.
Okay.
Good luck, Dr. Siraj. Thank you.
Thank you. So, okay. Assalamu alaikum. Now, my name is Siraj. I'm one of the consultants in internal medicine. Can you hear me? Mike, hello, can you hear me? Hello?
Yes, doctor, it's clear.
It's clear, perfect. So, my learning objectives for today are to discuss the reasons for reporting medication safety incidents, to talk about the types of reportable medication safety incidents that we would like you to tell us about. I'm going to tell you what information we need so that we can actually action any thing that needs to be done after a medication safety incident. Then we'll talk about some of the medication errors and near misses that have occurred in our organization, and then we'll go through the mistake lesson learning cycle. But before we do that, I'd just like you to think about a situation. If you just imagine that one of your loved ones is coming into hospital for an operation, and it's a very minor operation, you're expecting everything to go very well, and the surgeon says, you know, just wait in the ward, your loved one will be back with you soon, don't worry. But you're waiting, the time goes by, and sometime in the late afternoon, the surgeon comes to you and he says, you know, I'm very sorry, we didn't even do the operation because unfortunately your loved one had a cardiac arrest in the OR. How will you feel? You'll be shocked, devastated. You'll wonder what could have happened? How could this happen? So this is just one of the incidents that occurred in our hospital that we had to investigate and work out what happened. So can anyone just tell me what do you think could have happened during this operation for the patient to have a cardiac arrest? Now, I'll give you a clue that because this is the medication safety course, it is going to be a medication related issue. So what medication related issues do you think could have happened that caused this very sad event? Okay, so we'll. Hello, is anyone able to answer? What sort of medication errors do you think could have happened? Mm-hmm. Okay. Hello? Is anyone answering any questions?
Doctor?
Yeah.
I think they cannot respond through voice. They can only respond by chat.
Yeah, but there's no answers in the chat either. I can't see anything in the chat. Are they able to answer in the chat? Anyway, I'll carry on.
Okay, maybe the questions can be in the end of the presentation, Doctor.
I mean, the issue is I was just trying to make it a little bit interactive with the with the people, but with the attendees. Okay, so essentially, there's a few things that could have happened. So maybe there was a dose error. Maybe there was a medication overdose. Maybe the anesthetist gave too much medication. But what happened in this case was that the patient went to the recovery area. They were fine. But they were starting to become a bit anxious whilst they were waiting. So the nurse asked the anesthetist to give something to the patient to relax them. So the anesthetist was with another case, but he came out. He gave an injection and then went back into the OR. But unfortunately, he made a medication error. So he gave the wrong medication. He wanted to give midazolam, but unfortunately, instead injected rocuronium. Rocuronium is a muscle relaxant. It causes paralysis. So the patient became very calm and relaxed. And so the nurse and the anesthetist were initially very happy. But unfortunately, the patient then stopped breathing. And so the nurse immediately called the anesthetist, who rushed the patient into the operating room, and CPR was initiated, and he intubated the patient. And then they realized the error that had occurred. The question is, how could this happen? And this is a unfortunate complication of two medication ampules that looked very similar. So rocuronium initially used to be provided in a glass ampule. in a glass vial with a rubber bung. However, the normal supplier of rocuronium was not able to provide this to the hospital. So the stores changed the supplier to a different one, the same supplier who supplied midazolam. And so the ampules for midazolam and rocuronium were now identical. So the anaesthetist had both ampules out on the counter. He unfortunately picked up the wrong one. He says he looked at it and checked it, opened it, drew up the medication, and then administered it to the patient without any independent double check. He was busy, he was trying to help the patient in the recovery area. He had a case that he was anesthetizing at the same time. So there were many distractions that made this error much more likely to occur. So this error caused significant harm and required an extensive amount of investigation to determine the cause of the error, and then go on and implement changes in the organization within the operating theatre to ensure that this sort of thing never happens again, inshallah. So this is the role of the medication safety team. Now, when we think about that event, sorry, next slide. Is the next slide? Okay, there. So it raises multiple issues about reporting. So we certainly have an ethical and medical legal obligation to report. So families have a right to know what happened, but it's just as important to identify the hazards and the risks in our system. So once an error occurs, it's important to report it so that that error never happens again. But reporting potential errors is a very proactive way of making the system safer for everyone. And actually, potential errors are probably 200 to 300 more likely, 200 to 300 times more likely than actual errors. And it's important that we share and learn from our experiences. So if a error happens in one organization, sharing it can reduce the risk of it happening around the world. So next slide. Thank you. So what to report? So we want you to report any medication safety incident. And so there are two different types. We have medication errors and we have adverse drug reactions. So a medication error is an adverse drug event that has actually happened. Okay. So these must be reported. But to improve the safety of the system and identify risks, we also want you to report potential adverse drug events. So these are hazardous conditions and near misses. So if we think about the example that I gave of the anaesthetist who injected the wrong medication, the hazardous condition is the change in the ampule of rocuronium. So this is not a mistake. It's not, there's nothing wrong with it, but it creates a situation where an error can occur if the policies and procedures are not followed correctly. So had someone noticed, okay, you know what, the ampule of rocuronium has changed. It now looks very similar to midazolam. We need to be very, very careful, and highlighted this. This could potentially have prevented this event from occurring. A near miss is a situation where an error has occurred, but it's prevented from reaching the patient by our policies and procedures. So, for example, had the anaesthetist drawn up the rocuronium and done an independent double check, and that second person had identified, this isn't midazolam, this is rocuronium, that would have been a near miss. And those should be reported as well. Although it demonstrates our system is working, it gives us the opportunity to make our system safer by trying to eliminate the hazardous conditions. So another class of adverse drug events are adverse drug reactions. So they are different from medication errors because there's been no problem with the prescribing, dispensing, monitoring or administration of the medication. It is an unfortunate, severe side effect of that medication. We want those to be reported so that we can actually think about how we can make the organization safer by choosing drugs with the lowest risk of side effects. So when we think about what we want you to report, nausea and diarrhea are very common side effects of many medications. These are not things that should be reported through the adverse drug reaction reporting system. We're much more interested in things like heparin-induced thrombocytopenia. So this is a very severe reaction to heparin that's very rare, but it can cause people to have thromboses. The treatment is to stop the heparin and to change them to another medication. So reporting this adverse drug reaction is very important, because if we notice that with a particular batch of heparin we're getting a lot more events, then we need to change the supplier or think about changing our routine prophylaxis from heparin to fondaparinux, for example. So there's many things that we can do, but the only way we can effect change is if we have the information from what's actually going on in the hospital. Mike, can you advance to the next slide? Thank you. So examples of medication errors are prescribing errors. So almost all medication errors begin with a prescription. So that comes from the doctors, and I'm working to think about how we can improve that. Dispensing and preparation errors, administration errors, monitoring, dose adjustment, wrong patient, wrong medication, wrong formulation. The list goes on. But one thing that sometimes people ignore or don't think is important are omitted and delayed medications. So next slide. So these can be potentially very serious. Okay, this is a report from the UK, and over 3 years, between 2006 and 2009, 27 deaths and 68 severe harm incidents resulted from omitted or delayed medications. So what sort of medications might that be? Well, if a patient with heart failure has pulmonary edema and they need to have a diuretic, if that medication is delayed, the pulmonary edema can get worse and they could have a respiratory arrest and die. So other examples are antibiotics. Patients coming in with severe infections need to have antibiotics as soon as possible. Delaying the dose of antibiotics, even for a few hours, significantly increases the risk of death. So delayed and omitted medications are a very serious problem. Next slide, please. Okay, so what do we want you to report? Sometimes we get reports saying, the doctor wrote an order, I noticed it was wrong, and I called them and told them, and they shouted at me and they were rude, and so I just dispensed the order and administered the order and that's why the error happened. I'm very sorry if the doctors are rude and they shout at you. This is obviously upsetting and wrong. However, what we need is a factual description of exactly what happened, how it happened, why it happened, and what happened to the patient, particularly if they needed any additional blood tests or investigations and any monitoring that needed to be applied as a direct result of the medication error. Like the example with the rocuronium and midazolam, we need the names of the specific products and the companies if there was a problem with packaging and labeling. So these are the details that we need you to tell us when you report through the safety reporting system. Thank you. Next slide. How do you report? As I've just said, through the medication errors are reported through the safety reporting system, and the adverse drug reactions are reported through best care. Okay. Next slide. Okay. Now, what happens to the report? So, when a report is filed, we consider how severe the harm to the patient was. So, if there's no harm or only an increased monitoring is required, then we record that data and it's discussed within our committee meetings. And if there's significant numbers of harm events from a specific medication, we'll consider implementing changes to prevent that from becoming a more serious problem. If significant harm actually occurs to the patient, we organize a huddle. What that means is we get all the relevant departments and specialties together and meet and decide what we're going to do right now to prevent this from ever happening again. That's done in conjunction with the Quality and Patient Safety Department, so that we have a coordinated response to improving patient outcomes. Next slide. So most people are more concerned about what happens to me. So if you've made a medication error, you know, what will happen to you? Well, the Ministry of National Guard operates a just culture. So what that means is that you are accountable for your own actions, but if the system has caused the problem, then we recognize, and as in the majority of the cases, it is actually a system failure rather than an individual problem. So we do this so that we encourage reporting, so that we can learn from our mistakes and ensure that our system is as safe as it possibly can be. But we need to manage behavioral choices. So, for example, the anaesthetist who didn't do the independent double check, he needed training and supervised practice to ensure that he recognized the importance of performing the independent double check and the role of that in improving medication safety. Okay, so doing this means that we create a learning culture rather than a blame culture where people are penalized for every error, and so we have an open, fair and just culture. Next slide. So this slide shows the categories of medication errors. So category A and category B are errors that did not reach the patient. Category C and category D reached the patient but did not cause any harm at all. E, F, G and H are much more severe. So H and category I is the most severe. So category I is death. Category H, an error that occurred required intervention necessary to sustain life. That's the level that the administration of rocuronium instead of midazolam caused. Next slide. So we can see on this slide the number of monthly incidents that are reported over 4 years in our hospital. So you can see there are some peaks and there are some troughs. So the troughs are pretty much mostly related to the vacations. So when people are away for the Eid vacations, the reporting drops. That's because people are thinking about their holidays, not because the organization is any safer at those times. And in fact, because we have fewer staff and only the most sick patients are going to be coming to the hospital, actually it's more likely that the organization is more dangerous at that time. So we need you to give us reports all throughout the year. Next slide. So the number of reports pretty much has been increasing year on year. Now there was a slight dip in 2017, but if we take a look at the number of harm incidents, next slide, we can see that until 2017 there was a significant drop in the number of the percentage of the incidents that actually caused harm. So although the number of reports was increasing, this reflects that we have a healthy culture in the organization that is encouraging reporting. And the fall in the percentage that reflect harm suggests that we are becoming safer. There was a slight increase in 2017, and we've been working to look into that. Next slide. So if we look at the types of errors that occurred, so we have the vast majority do not cause any harm. So the vast majority are from A to D, and these do not have these are not associated with harm to the patient. There are very, very few that cause harm. So, however, the incidents that result in category C and D errors actually reach the patient, which means our system failed. So we should look at these more closely as an organization, but alhamdulillah, we have very, very few events that actually cause significant harm. Next slide. So what do we learn from the data? Well, we learn that errors or nemesis occur, and we need to recognize that they have occurred and report them. We then need to analyze that error and find out exactly what happened, so we can initiate a correction response that improves the safety of the system. That's not enough on its own, because we need to monitor that our recommendations and changes have been sustained to prevent that error from ever occurring again. Okay, thank you. Next slide. Because that's important, because medication safety is a team sport. Thank you. So, Mike, shall we load up the next presentation? And hello.
Go ahead, doctor.
Okay, perfect. So now, so this is the final presentation of this afternoon. So I'm sure you'll all be aware that you have an exam that you have to pass in order to practice in the hospital. So this is just going to summarize some of the messages that we've been going through today. And next slide. The first and most important thing is we want you to remember to follow the policy. Okay, what that means is you need to know the policies, and if anyone is having any difficulty sleeping, you can read the policies in the internet in the one-stop resource. But the policies are there for your protection. Do no more, do no less, follow the policy. Next slide. Do not try and reinvent the wheel. You are the best healthcare professionals in the whole of the kingdom, and you're very intelligent, and you have very, very clever ways of developing new ways to do things. However, the system has been designed to ensure the maximum safety. So please do not try and reinvent the wheel and just follow the policies. Next slide. Remember that the system has been designed to try and be as safe as possible. We recognize that sometimes it's actually the system that is at fault, and what we would like is that you highlight those situations as hazardous conditions so that we can improve our system. Go on, next slide. Keep things simple and standardized. Don't make things unnecessarily complicated. If you can use one medication rather than 3, use one medication. Okay, next slide. We need to change the culture to asking, how did it happen? When I spoke about the anaesthetist, I'm sure people were thinking, who did that? How could they do that? But if we just focus on the who, we will never actually make the system safer. We need to know how it happened. Next slide. What that means is we have to have a just culture where we recognize that individuals are accountable for their own actions, but the system, when it is at fault, that's recognized, and the focus should be on ensuring the safety of the organization by ensuring that people are accountable for their actions, but are not blamed for things that are beyond their control. Next slide. Because unless we have a just culture, people aren't going to report medication errors. And the most detrimental error is failing to learn from an error. Next slide. Next slide. Because some people watch things happen, some people wonder what happened, and some people make things happen. And we need you to make things happen and make this organization as safe as it can be. Next slide. Read back. So when telephone orders are made, there is a policy for how this should be done. So what should happen is it can only occur in a acute situation where a patient requires treatment urgently, and the physician is not immediately available to order the medication in the system. So, for example, if a patient on the floor is seen by the medical team and they have heart failure, the team think, okay, the patient's improving, let's stop the furosemide today. But then the team move on, go onto their duty in the cath lab, and so now the physician is scrubbed in the cath lab. The nurse on the floor notices, the saturation has dropped. The patient, we probably need to give the Lasix again. So they call the physician who's in the cath lab, and he says, I can't come to put the order in the system now, but can you give 40 milligrams of furosemide stat? So what needs to happen is that the policy for telephone orders needs to be followed. So the nurse needs to record the doctor's order. The doctor needs to order the medication very clearly. I want you to give 40 milligrams of furosemide now, please. The nurse will document the order, and then a second nurse will read back the order to the to the physician who made the telephone order. So in this way, we reduce the risk of errors from miscommunication and transcription. Next slide. Independent double check. I've already spoken about the importance of the independent double check. It is vital that it is a double check, and it's vital that it's done independently. So two nurses do not look at the same ampule together, and nor does one nurse just give give another nurse their badge number so that they can just authorize things without actually doing the independent double check. Next slide. Medications that cause the greatest harm: opioids, anticoagulants, insulins, and chemotherapy. These medications are very important, but they're also very dangerous. They have a very narrow therapeutic index. Overdoses can be very dangerous. You need to be very vigilant when you are prescribing, dispensing, and administering these medications to make sure that the correct dose is given. Next slide. Basically, if you have any questions about medication safety, you need to look at the one-stop resource. Next slide. Communication, IS-bar. This is the standard way that we have we've decided that the communication should be conducted about emergencies in the hospital. You need to identify yourself, explain the situation, go through the background, explain the assessment that you've made and your recommendations. In this way, people are in tune with what is happening with the patient and can give it gives a clear structured appraisal of the situation, so that the person you're communicating with can give you a sensible response, inshallah. Next slide. Educating the patient is critical. The patient themselves are the last independent double check. They can only sort of be involved with their own healthcare if you actually tell them exactly what is going on each step of the way. Next slide. Anaphylaxis. How do we treat anaphylaxis? Epinephrine. How do we give it? IM. So some of you will notice that around the hospital there are some screensavers that are showing reminders about medication safety events. So one of them shows this slide. The reason it shows this slide is because a patient had an anaphylactic reaction, and the epinephrine was unfortunately given IV. So the patient's anaphylaxis improved, but unfortunately they developed ventricular tachycardia. Please give the epinephrine IM. Okay, and this should be available in the anaphylaxis kits. Next slide. Using abbreviations saves minutes. Prohibiting abbreviations may save lives. So as healthcare professionals, we're in the business of saving lives, not saving time. And the problem with abbreviations is that people may not understand exactly what they mean. Next slide. If in doubt, check it out. Where should you check it out? On the one-stop resource. If you don't find the answer there, you need to call the physician and discuss the prescription with them. If they don't give you a sensible answer, you need to move up the food chain. You need to contact the consultant. If they don't answer, you need to contact the head of department or even the chairman of the department until you get an answer, because if you don't give the medication safely and correctly, significant problems can occur. Next slide. Eliminate the denominator. Put a face on the data. So we get used to talking about the patient who is in Ward 8, Room 3 boy. The nurses unfortunately play musical beds and they shuffle patients around. So unless you talk about the patient's names and histories, they you can actually be talking about different patients. So it's important to do this so we are all on the same page, talking about the same patient. Next slide. Embrace the power of storytelling. There's no better way to inspire and sustain change than through telling stories. And that's why throughout this course, we've been telling you stories about our experiences of medication safety and medication errors that will hopefully inspire you to follow the policies and procedures to prevent medication errors and report to us new problems that occur. So any medication safety incident that you're involved in, we can try and help the medication practices improve in this organization, but only if we know what's happening. Next slide. When a medication error occurs, we perform mini root cause analysis. We keep asking why until we find out what happened. Next slide. If you need more than 3 dose forms to prepare or administer a dose, check it out. So this is a very important lesson to learn. So a patient was ordered digoxin, and unfortunately, if the dose is ordered in milligrams rather than micrograms, then the 1,000 times increase dose error can occur. So this has actually happened. People have actually administered large doses of digoxin because of transcription errors. So if you need more than 3 dose forms, 3 vials to prepare or administer a dose, think very carefully about whether the dose is correct. Next slide. Don't assume, always confirm, always check it out. Okay, next slide. It's not comfortable, it's not rocket science. Be comfortable with what you do and feel safe reporting. Okay, next slide. Safe patient care is our goal. Good. That's been a rapid run through of medication safety and the clinical pearls. And I wish, so inshallah you'll do very well in your exams. Thank you. Okay. Does anyone have any questions? Hello. Hello. Mike, hello.
Yes.
Good. Can you just type a question in the chat, or just type something in the chat just to see if this is actually working? Because I don't know if anyone's actually listening.
No, I can hear you.
No, I know you can hear me.
A separate attendance link.
There's a separate attendance link, but the others. The question is, I don't know if they were able to hear. Does no one answer any questions? And where should the chat appear?
We have 53 attendees still watching.
Okay. Okay. Anyway, so I mean that's the end of the course. I can't see any questions in the chat, so I guess.
Abdulaziz says thank you. Mariam says thank you.
Where is this chat appearing?
I can see them. Crystal clear. Thank you for your presentation. We are listening. Thank you. We can hear you. Thank you, Dr. Siraj. We heard you. I don't have questions. Thank you. We hear you, sir. Everything is clear from my end. So that's some of the
Okay.
comments.
Okay, thank you. I don't know where these comments are appearing because I can't actually see them.
Yeah. I'm not sure where, but I can see all the comments. No questions. One anonymous said everything was clear. Thank you.
No problem.
Thank you, doctor, for the informative presentation. Thank you. Thank
Fine.
you. Thank you.
Okay, good. Thank you. Thank you. Okay,
All right. Okay. Thank you, Dr. Siraj. Thank you very much.
Thank you, Mike. Thanks for sorting this out.
All right. Okay. For those who are listening right now, you can I can see your comments, and the exam I sent the link yesterday with the access code and password. Actually, the password has the same password. It's BMS 2020, but you have a different access code. And the exam will start 5:30. It will be open 5:30. You can copy the link through copy the link and paste it in the Chrome address, so you can go to the website. Or if you click the link and you did not find the website in the Chrome, you can copy and paste the address link to the address of Google. It's clear? Okay. The exam will take about, if you finish, if you listen carefully, you will be able to finish it maybe 20 minutes or less. But the exam will be open from 5:30 to 8:30. So you still have time. Okay, so 5:30 until 8:30. Okay, and once you pass the MCQ, it's only 20 questions. I don't think you can repeat. So it's a one access code for one student. It's unique for everybody. And the question will be randomly appear to your screen when you click the link. So the number one of the student is the different question number one from a different student. Okay, there will be a certificate of completion once you finish the exam. But if you fail, there will be an email for you that you'll have to repeat. Maybe we'll request to Miss Dina. I'm sure you know Miss Dina what to do. Okay, again, the exam link will be open from 5:30 to 8:30, but you can finish it maybe 20 to or less than 30 minutes. If someone fail, what's the next step? Okay, I'm sure you listen carefully, and some of the questions are just true or false questions. Yes, you can open it from iPad and iPhone. Okay, just read the instructions that I attached in the email very carefully. I will show you again. I will be here until 5:30, and then you can get the you can log into the exam. Yes, you can go back to the question, to the previous question. Again, it's from 5:30 until 8:30 p.m.
Hello, Michael.
Yes,
What about now? Is it okay now?
until 5:30. I'm just answering
Until
some of the questions.
okay.
Again, the exam is open from 5:30 until 8:30. The duration of the exam is open for 3 hours, but you can finish it with maybe 20 minutes. Once you pass, there will be a score that will be sent to you. You will know it, and then a certificate of completion will appear, and there will be an uh, email announcement of your of you taking the exam. It's like a reply email. Okay, read the instructions on how to do the exam. I posted it here. It's very small. The attachment is the instructions is also attached in your email. I emailed it yesterday afternoon. Yes, you can take exam maybe by 6 or 7. For the one who asked if we can extend until 9 p.m., I'm sorry, it's limited up to 8:30 only. It was set to be open until 8:30 only. Okay, the username and access code was sent yesterday again through your KSAU email address. The attendee link for today's course and the link for the exam below the link attendee link for today. So you can see it below. Okay, so again, once you pass the exam, a certificate will be issued that you have completed the exam only. Okay, and then once we confirm it, there will be another certificate that will be sent to you, copied to Miss Dina, the admin. You will get the score right away once you are finished with 20 questions. All right, by this time, I believe the exam link is open. Just remember, if you click the link and there's another, click the link to the website. If that does not give you the right address, you have to copy and paste the link to the Google Chrome. All right, and good luck to everybody, and thank you.
Hello, Mr. Michael.
Yes,